Thank you so much for joining us today. I want to welcome everyone to this installment of the STS 2022 webinar series. This series features presentations and panel discussions on a variety of topics relevant and important to cardiothoracic surgeons. This topic today is new FDA-approved aortic technologies. STS would like to acknowledge the sponsors of tonight's webinar, WL GORE and Associates, and Toronto Aortic. Please note, this webinar will be recorded and will be available on the STS website and YouTube channel. We invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. At this time, I am pleased to welcome our moderators, Drs. Arminder Jassar and Dr. Chad Hughes. Dr. Jassar, welcome. I'll now turn it over to you.
Good evening, everybody, and thank you for joining us today on this webinar on the new FDA-approved aortic technologies. We are very excited about this, both the product and our session today. These are two devices. The first one, a GORE single-branched endograft, and the second one, a Thoraflex Terumo hybrid frozen elephant trunk prosthesis that have been available only at select centers so far as part of their U.S. clinical trials. But now with the approval of the FDA, these devices are available to all members, all surgeons that would like to use them. So we thought it was a good time for us to have this introductory webinar for us to introduce these devices. Everybody has seen them, everybody heard them, but now there's an opportunity for all of us to use them. We have a great panel today. I'm very excited to introduce them. My co-moderator today is Dr. Chad Hughes from Duke University, a very experienced operator in both devices. Dr. Claire Watkins joins us from the Stanford University Hospital, and Dr. Desai from University of Pennsylvania. So Dr. Desai and Dr. Watkins are going to show us some of the cases that they've used the TBE device for. And then we have Dr. Preventza from Baylor College of Medicine, and Dr. Shrestha, newly from the Mayo Clinic in Rochester, who are going to share with us their experience regarding the Thoraflex hybrid. And we'll save some time for questions and discussion at the end. So without further ado, I'm going to turn it over to my co-moderator, Dr. Hughes, to introduce the TBE device.
Good evening, everybody. Thanks for joining us. I'm going to just give 2 minutes on the GORE TBE device that Arminder just told you about. We'll hear 2 cases, as mentioned, one an aneurysm case and one a dissection case. This is the GORE device. It's a device designed for arch pathology, whether in zone 2 or more proximal, zone 1 or even zone 0. It's based on the GORE C-tag device. And it's unlike some of the branch devices that are out there, it's designed to be deployed or placed mainly from a femoral or a single access site without any need for upper extremity access. It can be zone 2. Again, this is an example of a zone 2 case of ours, or a zone 0 with an innominate branch. It's currently the zone 2 trial is over. The zone 0 trial is finishing up. The zone 0 generally involves a cervical bypass with plugging the left subclavian and a branch into the innominate, whereas the left subclavian patient had total arch with the completion zone 2, and it gets rid of the need for quad subclavian bypass in that situation. Device can treat diameters from 16 to 42. The landing zone measurements are a little bit different than what you're used to, in that the landing zone starts at the back end of whatever branch vessel you're going to land in, and extends up to the back end of the next vessel, whether it be generally subclavian or innominate, but it can be used in the carotid. That wasn't used much in the trial. There's 3 components: the aortic component, which has a portal, either 8 or 12 millimeters, and then the side branch, which goes into the target artery, and there's these short aortic cuff extenders, which can be used but don't have to be used. The device The aortic component can treat from 16 to 42 millimeters, which is a 21 to 45 millimeter device. There's an 8 millimeter portal devices, and then for the 8 millimeter portal devices, this proximal segment is 2 centimeters. And then for the 12 millimeter portal, which generally would be the innominate portal, the leading edge is 4 centimeters, as that's generally going to be a zone 0 landing zone. The side branches come in 2 sizes, and the 8 millimeter portal size, which is generally going to be left subclavian or left carotid, or 12 millimeter, which is generally going to be the innominate, and these can treat up to a 15 millimeter vessel with the 8, or an 18 millimeter vessel with the 12 millimeter portal. And for the 8 millimeter portal device, you need 3 centimeters of landing zone in the branch vessel versus 2.5 in the innominate. The aortic extenders are just short cuffs that the overall device lengths are from 3.6 to 4.6, but generally it's 3 centimeters to 4 centimeters of covered fabric that can be used to extend your proximal landing zone if needed. And then this is just quickly how the device works. Generally, you get aortic access like you normally would, and then a second wire is passed up from the same access in the groin out to the target vessel. And then the device actually has has a main center hole where the main heavy wire goes in. There's a side portal that has a special way you feed it through there that orients the portal to the outer curve. The aortic components then pass up. Main thing here is make sure you don't have wire wrap and that you have your portal to the outer curve. And this is pretty easily done under fluoro. And then the aortic components deployed first, and then the side branches advanced and deployed. Generally, you balloon the portal and possibly your landing zones. So that's kind of a brief overview. And I'll pass it over to Claire Watkins, who's going to talk about a TBE for an aneurysm case. So thank you.
All right, thanks, Dr. Hughes. All right, so I'll show you an example of a GORE thoracic branched endoprosthesis for an aneurysm. I'll refer to it as TBE, which I think is pretty common. A 77-year-old with kind of a boring little saccular aneurysm right next to the left subclavian. The distance between the left subclavian and the aneurysm was only about 3 millimeters, so it definitely needed a zone 2 solution. And so Dr. Hughes mentioned the sizing a little bit. I'll show you how I sized this case. I measured at the distal edge of the left carotid and in centimeter increments beyond that. And an important measurement to take, like Dr. Hughes said, is that distal edge of the left carotid to the distal edge of the left subclavian. And in this case, it was nice and long at 29. Most TBEs can be done with a 2 centimeter landing zone. That landing zone requirement does change a little bit with the size of stent you're using. So for our measurements, with the landing zone at about 31, that was led us to use a size 37 device. And here at the sizing information, again, that important landing zone length, which is measured right here from where the fabric starts to the end of the portal, which will be the distal edge of your subclavian. That's called the proximal covered length, and that's 20 centimeters. You can see the range for different sizes. And then in sizing our side branch, again, measured the subclavian at the ostia and in centimeter increments distally. And the important length measurement to get here is from the aorta to the, vert and to the left vertebral artery, excuse me. And the length we had here was 45 millimeters, which is pretty generous. So measuring our left subclavian at 12-13, we used a size 15 side branch. And again, the length that you need to the vertebral varies with the size of side branch that you use. So you want to look at this required branch vessel length and make sure that here we had 45, but we only needed 30. About 25 millimeters of the side branch goes within the portal, and the rest kind of makes the curve out into the side branch, and this bigger part here is your sealing zone that is your 15mm diameter. So the procedure started with femoral and left radial access. This is our initial angiogram with a little small aneurysm there. Through the 5 French access in the left radial, we advance a very long glide wire. It's going to be a through and through wire, so it has to be over 350 centimeters generally. And we use a snare here, and usually in the descending thoracic aorta, anywhere really, to snare that long glide and pull it out the groin access for your through and through access. So then you load up the device onto both your wires. Actually, let me stop that because I want to talk about that separately. Your stiff aortic wire goes through the middle of the aortic component like a traditional TVAR. That's your Lunderquist or Amplatz. And then that through and through wire goes through the portal itself outside of the body. They give you a nice little kind of tube exchanger where you put the glide in and then pull it through. And then you advance the device up with both wires. With a little bit of tension on that through and through wire. And I recommend having a sheath or a catheter here to kind of protect the subclavian intima as you pull taut on that. This is what the radio-opaque markers look like. And this is the portal. This is where your side branch bends out of it. Yeah, the one thing that the probably most technical aspect of this is avoiding wire wrap. And you can see in this video, we do initially have some wire wrap. That through and through wire, touchy mouse, excuse me. That through and through wire is coming underneath the aortic component and the portal is here on that inner curve. That's what you want to avoid. You want the portal out on the outer curve. The way to avoid that is with good tension on the through and through wire. And so you can see in this video, we pulled it back. We rotated the device a little bit. It has some pretty good torqueability. Right here, we're rotating it. So you're able to change the position a little bit here. And then as you go up, pull tighter on that through and through will help avoid wire wrap. And we eventually get that to the outer curve there. Next, we deployed our device with this radio opaque band right here is our fabric, right as close to the left carotid as we can. And then deliver the side branch from below over the through and through wire. Again, with a little, watching that right here as you pass into the portal that you don't distort it. And again, pulling taut to help it get through there. You can see we have a little trouble getting it, and that's because there's too much redundancy on this through and through wire, and the person at the groin isn't pulling tight enough. When they do, the side branch tracks nicely up where it's supposed to go. This is a moment that requires good communication between the arm operator and the femoral operator. There we go. So then through your sheath or catheter, whatever you have in the arm, you can take another shot and really make sure you're confident in the location of your left vertebral and deploy the side branch. There it goes. We balloon the whole portal and side branch, generally with a MOB balloon, also made by GORE. And then this is our completion angiogram, and you can see that little blip is nicely contained, and our side branch is widely patent. This is the patient's result at 3 years. She was done as part of the trial. And with my last minute or so here, just going to show some pre and posts of zone 0 aneurysms to really, even though TB right now is only approved for zone 2, to let you see the potential and what is coming down the road. So this is a big saccular aneurysm. The patient has had a carotid left subclavian bypass. And this is their result at 1.5 years. Nicely contained. Again, another large arch aneurysm treated with a cervical bypass and single side branch in the zone 0 position. So I'm sure your local GORE people can provide more information if needed, but I'll pass it on to Dr. Desai to show a dissection case.
Wonderful. Thank you, Claire. That was amazing. And so I'll just carry on the theme here, and we'll switch over to talking about using the GORE TV device for zone 2 repair in aortic dissection. And this is an area that, we started down this road or in the early feasibility trial of using the device as basically a completion for a zone 2 arch. And I wanted to show our technique for that, and then using it in a de novo dissection as well. So just to reiterate and hammer home this key point about sizing. All the standard TEVAR sizing metrics are obviously important for sizing to the aorta, but one of the things you have to understand very well here is understanding the proximal covered portion of the graft and knowing how much landing zone you're actually going to have. And I think we've seen how that's done really well in the past 2 presentations. And it's just important to note there are those 2 portals. There's an 8mm portal that has the shorter 2cm proximal covered length, and the 12mm portal that can take also has larger side branches and has a longer proximal covered length. Ideal for zone 0 deployment, but it works really well in zone 2 as well if you're landing in a graft or if you are dealing with a bovine trunk or just a patient that has a longer zone 2. So one of the key things about planning these cases is really making sure you understand the anatomy that you're looking at. So you always have to use good 3-dimensional imaging, whether it's tear recon, M2S, Osirix, or whatever you have, especially when you're up in the arch. You really can't use axial imaging to measure out the size of the aorta or to plan your case out well. Even in an emergency, hopefully you'll have access to 3-dimensional viewers to do that. Along with the normal measurements that you'd be doing for a TEVAR, some of the things that are important are to understand that proximal segment from the distal origin of the left carotid artery to the distal origin of the LSA. In this situation, the proximal covered length, which is from the center of the left carotid to the distal origin of the LSA, is 3.4 centimeters. And that is less than 4 centimeters, which is what you would need for the 12mm portal. So in this situation, we're using a device with an 8mm portal. And that's really important because that is going to determine which device you're using and which side branch you're using. So it's important information to have as you're planning the case out. Additionally, you want to look at that subclavian artery if you're landing in zone 2 and make sure you know what the distance is from the aorta to the vertebral to make sure you don't cover it. And also to make sure you know what the diameter is. And in this case, the diameter is 11 millimeters. So I'd probably take a 13mm side branch in that situation. That's sort of some of the concepts behind the sizing. I'll just show you a couple of quick cases of what we do with it. This is a patient that had a acute type A dissection that had a repair with a zone 2 arch. And we built this really long proximal landing zone in order to stent it with the TB device afterwards. And so this is the procedure here. As with all dissection TEVAR, you should always use IVUS to make sure that it's in the true lumen. It's particularly important for the TBE cases to be sure that both wires are in the true lumen. So remember, as Dr. Watkins showed you, there's a wire from the subclavian and a wire from the in the aorta that goes into the ascending aorta. I think our wire here is actually sitting in the ventricle. That both of these wires have to be in the true lumen. That's critically important. If they're in different lumens, you're going to fenestrate the aorta and probably have a bit of a catastrophe, when you deploy the graft. So IVUS to make sure both wires in the true lumen, and the externalized wire, as Dr. Watkins showed earlier, is from the arm is brought out through the groin, through the GORE sheath, and placed in that second portal lumen of the device. And the device is brought up. One of the things that we're really careful about is wire wrap. So the rotational alignment of the device is very important. And typically, if you're pulling a little bit on the through and through wire, the device will straighten itself out as you put it up. It's also very important to leave the wires in the right orientation as you're going up the groin. And that can help prevent any wire wrap, which would make it impossible to advance the device. So here we're advancing the device. There's actually a bit of wrap here. So we pull it back and then re-advance it and turn it, and we bring it into the final position. Now here's the TBE device as we're about to deploy it. So this is the main body over Lunderquist wire. We're landing in that zone 2 arch graft that I put in previously. Our branch is in the left subclavian artery, which you can see here with the through and through wire, and we're ready to deploy. This is a surgical graft that actually has some markers on it to show what our distal anastomosis was as well. So here we're taking we're about to deploy, and now we deploy the graft into the surgical Dacron graft proximally. And now you can see the portal here. In this situation, because we're landing in Dacron graft, I'm using the 12mm portal with the 4cm proximal segment. And here's an angiogram just showing that deployed now. And now we're deploying the left subclavian branch into the portal. And as Dr. Watkins showed earlier, we always balloon. I usually use a Coda balloon to balloon the branch. When I'm landing in Dacron graft, typically I will first balloon the proximal landing zone, then I'll balloon the branch after that. And then typically with these cases, we'll extend distally as well. So just a quick second case just to show how to troubleshoot some of these cases or understand what to look for, because branch technology in the arch is brand new. This is the only FDA-approved device for endovascular repair in the arch like this. This is a patient with a chronic dissection that was a couple of years old, had a dilating distal descending aorta, proximal landing zone of 41mm. You can see the landing zone here is short, so we're using the 8mm device, very compressed true lumen distally. And in our distal landing zone, just above the celiac, true lumen of about 14mm, false lumen of 30, so a total diameter of 44. And we can talk about sizing issues in that situation. But the reason I wanted to show this case is to show what happened when we put it in. So we had a really nice result technically. We put the device in, and when we scanned the patient at a month, we saw this small endo leak, this little gutter leak from where the subclavian was coming into the aorta. And we had spoken to GORE about this, and we were kind of involved with their trial right from the beginning. And the thought at the time was to just watch it for a little bit longer and see what happens to it. And like most of these in the trials that have been done, give it a few months and it actually thromboses off and goes away completely. And the false lumen was shrinking and the endo leak was resolving. So with any kind of branch technology, whether it's in the arch or in the abdomen, you may occasionally see things like little gutter leaks or little branch endo leaks. Typically they will go away with time. Sometimes they need further intervention like coiling, but we've never had to do that in the arch. So just to conclude, the TBE graft brings a whole new option to managing zone 2 landing in the aorta without having to do a carotid subclavian bypass. And I think everyone has shown that pre-planning technique and close follow-up are the keys to having good results. Thank you.
Thanks, Nimesh. And Claire, great presentations. We have like 5 minutes. So I'm going to give you each 2 questions. Maybe you can give me like a 2-minute answer to each one so we can stay on time. Claire, 2 questions, just answer them both. There's a question in the chat about CPT codes. I think we say that for the end and talk about that for both devices. But Claire, do you always have to snare? Or can you ever just do it without a snare or with a sheath? I know early on in the trial, they had this long 14 French sheath. I think they got rid of it. So do you always have to snare is one question. And then the second question is, who can we not do this in? Who do we still have to do subclavian revascularization? Maybe your two questions.
Yeah, sure. You don't always have to snare. I think it's much easier when you do. It helps, like I said, being able to pull on that through and through wire and give just a little bit of tension makes the single side branch really trackable. It also helps avoid wire wrap and keeping your portal on the outer curve rather than kind of anterior posterior. So no, you don't have to use a through and through, but if you can get a stiff wire out the portal and into the arm, but I just think it is much easier when you do. And then who can't get this device and might still need a carotid subclavian bypass, the biggest limitation is probably access. One of my slides had the French size is anywhere from 22 to 26. That said, people have, I know, have been able to kind of cheat a size down and squeeze through the smaller size on that chart. I don't think GORE would recommend that, but access is the biggest limitation. And then that landing zone that's between the distal edge of the carotid to the distal edge of the subclavian, depending on what size you're using, has to be anywhere from 17, 18 to 25 millimeters. So arches in which those two vessels are close together. As you know, in the short time that TBE has been commercially available, I know people are starting to cheat backwards a little bit, you know, on short landing zones, but that's definitely not the IFU. So both the landing zone and access can limit it, but the vast majority of cases that you'd be looking at a bypass for, I think are anatomically amenable to a TBE.
Thanks. Good stuff. Nimesh, two questions. So I assume most of these dissection cases are also going to need distal TVAR. Maybe give the audience just a minute or two about how you build that. And then the second question would be, you know, there's a movement, as you know, towards more extensive initial arch repair in type A, but you could also make the argument that if certainly, you know, from the preoperative CTA that the patient's anominate would be amenable to a 12 millimeter portal, what about going back to more of a hemi-arch approach at the initial operation, setting yourself up for a zone 0 TBE that would be a less extensive initial operation, you know, than doing a total arch replacement?
Yeah, I think that those are great questions. I think the sizing part for the distal sizing is always complicated. Approximately, you're trying to, in a dissection case, whether it's acute or chronic, you're trying to oversize as little as possible. So keeping it under 10%. I think ideally between 5 and 10% for chronics is probably good. And for acutes where you have really hostile proximal landing zones, you know, maybe even true sizing it to the aorta is probably enough. Distally, it's in chronic dissection, it becomes a whole different you know, ball game. And I think, you know, if you ask, I think all 6 of us probably have different algorithms for how we would do it. I tend to try to go outer to outer in terms of what I'm sizing, knowing that eventually that stent graft hopefully will expand all the way out and really compress that true lumen, that false lumen down. You know, we know there's a risk of having a stent graft induced anterior tear there as well. So I think that's something to be cognizant of when it's, you know, extremely compressed. But I tend to put in larger stent grafts to try and get better thrombosis and remodeling. I think there are lots of different ways to do that. If you're landing in a very big aorta at the diaphragm, that operation is probably not going to work over the long term for the patient. And you really have to be realizing that you're setting them up for some kind of open or endothoracal later, right? If the largest part of the aorta is up in zone 3, you know, these operations for dissection work really well. If it's in the abdominal or visceral segment, this is just a temporizing setup for something else. So that's sort of my concept behind sizing. And then in terms of the complexity of the aortic repair, I think, you know, you do the operation in the middle of the night that you're comfortable with. And, you know, we switched over to doing a zone 2 arch pretty routinely for most younger patients with type A dissection, probably about 7 or 8 years ago now. And so it's pretty much our go-to operation for anyone we think is going to live more than 10 or 15 years. And I think there is an evolving interest in looking at total arch debranching operations in patients who've had hemiarches. But if you're going to do that, you have to do that hemiarch right to make sure it's set up properly for it, for sure.
Thanks, Arminder. It's all yours.
Thank you. Let me start sharing my screen here. Okay, so I'm going to take just a couple minutes to introduce the second device that we're going to talk about today. This is the two-room aortic Thoraflex hybrid frozen elephant trunk prosthesis. These are my disclosures. So this device is going to be offered in 2 different variations. And I'm just going to go through what some of these sizes and numbers means. So it is a combination. So the device is a combination of a proximal surgical graft, either with multiple branches on it, or as I'm going to show you, without the branches, which is already pre-mated to Anaconda, which was an old stent graft design in early Europe. And the devices are pre-mated already. So there's no suture line here. It's all just one piece of stent graft that forms the full device. So the sizes are based on both the surgical graft diameter and the size of the stent graft diameter. The surgical graft lengths are pretty standard, but these diameters, as you see, can go up from 22 millimeters to about 32 millimeters. The device comes with a collar, just like you have in the regular Sienna graft, but this collar is much smaller. Most of the times we end up cutting up the collar on the Sienna graft anyways. And then you have some flexibility in the branch sizes. So you can either get a 12 millimeter, 8 millimeter, and an 8 millimeter branch device, or you could get a 10 millimeter, 8 millimeter, and an 8 millimeter device. There's a perfusion side branch, which is 10 millimeters in size. And then the stent graft portion comes in 2 different lengths. It comes in a 100 millimeter length or 150 millimeter length. And the diameters go from size 24 to a size 40. So for the smaller sizes, it's a combination of a 22 millimeter surgical graft to a 24 surgical to a 26 stent, a 26 surgical to a 28 stent, 28 surgical graft to a 30 stent. But for the 30 millimeter surgical graft, you have stent graft options to pick from a stent graft diameter of 32 millimeters all the way up to a 40 millimeter diameter stent graft. And then the 32 millimeter version comes with a 40 millimeter diameter stent graft. And of course, all of these combinations, the diameter combinations, are available either in the 10 centimeter stent graft version or the 20 or the 15 centimeter stent graft version of the device. Similar graft to stent graft combinations are available without the plexus branching system. This is for folks who either prefer to do the arch vessels as an island, or folks who use the Spielvogel technique and use a separate graft, which can then be anastomosed to the stent graft. But the surgical graft and the stent graft diameters are in the same combination. This is a very short video of how this device is deployed. It's a flexible device that you can bend to the curvature of the aorta, done without fluoroscopy, can be done actually with or without a wire to guide this. A wire probably helps, especially in a dissection case, so that you don't cross over the lumens. The device is inserted into distal open arch, and a pull of the handle deploys the stent graft portion of the device. So the difference, rather than doing a standard elephant trunk, we'll be using the standard devices, which are really long and meant for endovascular deployment. This is a short device that it can be easily managed. There's a bracket or a clip that holds or constrains the surgical graft, which is just cut to release the surgical graft. And then there's the final wire release that deploys the graft completely. And then the handle can then just be carefully withdrawn. And that's the end of the stent graft deployment. Then you have the Sienna cuff like you normally would, which you will attach with a running suture line. And then the branch grafts or the non-branch graft device whichever version you choose to use to then finish the rest of the arch reconstruction. And now I'm going to hand this over to Dr. Preventza to show us an aneurysm case using the Thoraflex device.
Great. I would like to thank the Society, first of all, for this kind invitation. And I would like to thank Dr. Jassar and as well as Chad Hughes for really putting this a great webinar together. And I think it's very important, especially with all these new FDA-approved technologies. So my task was to talk to show a case of a Thoraflex device on an aneurysm case. This is and this is my disclosures. So this is a 67-year-old female who presented to the emergency room with chest pain. Her workup regarding coronary artery disease was negative. And as we can see, her imaging study showed multiple circular aneurysms of the arch. And as we know, these circular aneurysms are not actually the same like the fusiform aneurysm. These circular aneurysms most of the times are related to a prior infection or inflammatory process, or the patient most likely you have to expect that there's going to be quite a bit of edema around the aortic tissue that makes the case a little more challenging. So we did all the pre-op workup and the patient was ready for surgery. Prior to a total arch procedure, I did actually a left subclavian to left carotid artery bypass, so can make the procedure a little easier, and we can talk about this during the discussion point. So we can see here that when actually we open the pericardium, there is all this edema and inflammation, and that was more consistent with this pathology that the patient has with these multiple circular aneurysms. And so the sequence of the procedure basically is axillary cannulation, cardiopulmonary bypass, via the axillary artery for inflow, and the right atrium myocardial protection with antegrade direct into the coronary ostia and retrograde. And regarding the brain protection, I like to cool down to 20 to 24 degrees, use moderate hypothermia. And then I like to protect the brain with bilateral antegrade cerebral perfusion. You can see here the arch vessels. Unfortunately, you cannot really see here the pathology well. And the reason is because that's why it actually makes the case a little more challenging, because everything is really on the arch and the proximal descending aorta. Here we're down into the 22-24 degrees Celsius. I have clamped the anominate, so we're actually on CircRS with unilateral antegrade cerebral perfusion. I have placed a wire through the groin, through the left common femoral artery. The reason is to just use it for the Thoraflex device, because I do think that actually, even though you don't always need it, can facilitate the placement of the Thoraflex device into the descending thoracic aorta. So we can see here when we when actually I divided the aorta, you can, I don't know, I hope that you'll be able to appreciate how thick was the wall. Actually, I have to use both scissors as well as the knife to be able to open this thick wall. So here we have the clamp into the anominate, and we are with unilateral cerebral perfusion via the right common carotid artery. Then I place a second ethmotic cannula into the into the left common carotid ethmotic artery. Prior to that, I ligated the left subclavian from inside. Because on the subclavian carotid bypass, I have not ligated the subclavian during the bypass. So it was much easier actually to ligate it when you see it from inside. And at this point, we are on CircRS with bilateral antegrade cerebral perfusion. This is a demonstration that we saw very well. Arminder actually saw before, placement of the wire, and then you pull the strap back, and the device is still constrained, and then you have to pull the red knob to have the device completely unstrained and deployed. So here is in the operating room, place the device through the whole of the this malleable shaft. And you can see here actually deploying the device. Here I should actually have hold this a little more steady, but I put my palm on it. You can see how this jump is actually a little definitely better to just like hold it with your hand there and deploy the device. Then the next step is you have to take this the blue strap off. The best way to do this is by using 11 or 15 blade. Initially, I tried to use the scissor, but the scissor really doesn't really work in this case well. The 11 or 15 blade works much better. And then I think this particular step is very important. I think it's very important to pull the wire from the groin first, prior to open this red knob. And the reason is because the device at this point is not fully deployed into the descending thoracic aorta, the part of the stent. So when you pull the red node, this is when the device here is completely deployed. And then what I did is that I use as the, actually Dr. Jassar make this point, and this is a great point. This Thoraflex device, when you use the collar is much actually smaller. You can see with the CN graft, when we use it, always we have to use the scissor to cut the CN graft. So here is we use the collar, we do the distal anastomosis, and then what I did is that I used the trial of GORE balloon to make sure that the end of the Thoraflex stent is fully expanded. And this is actually based on my past experience when we do the self-made frozen elephant trunk. But this at least gave me the peace of mind that the device is fully expanded. And we can see here on the transesophageal echocardiogram that the device is very well apposed into the aortic wall and fully expanded as well. And then the next step is to do the branch vessels, and I had to do the carotid and the anominate, but prior to that is I actually perfuse, we went back to full flow and perfuse the body. So at this point you have actually time to see how the configuration is going to be and how you are going to do the arch vessel, because you're back on full flow and the clock is not ticking. So here is the left common carotid. The size was small, was about 8 millimeters. So I put the 8 millimeter graft there. You can see when you cut short to length under the anominate vein. And we did the anastomosis with you can do it. I did it with a 5-0 proline. And then the next step is to do the anominate, and then I did the anominate anastomosis with another 4-0 and 5-0 proline. And then of course we did the proximal anastomosis, and this is the final product. And the patient actually did well. That was her CT scan postoperatively. I did this almost, I think like 2 weeks ago. She went home last week. The pathology report is still pending. That would be quite interesting to me, especially with all this thick wall that this patient had. We did also have sent some serology for syphilis, because as people know that all these circular aneurysms are associated with infection. So it will be interesting to see when we have the results. Here is actually the people that helped me in the operating room. You can see this is Dr. Chen. This is our cardiac anesthesiologist, great, and they have great fellowship program. This is, and with his fellow, this is one of our cardiothoracic surgery residents, Dr. Amelia, great hands and great judgment. I think it's going to be a great surgeon. Here is Melissa, the scrub tech, and here you can see all the perfusionists, Ling Ming, as well as his students. So I'm very excited actually that we use this technology. Dr. Moon also did another case last week and he used it, and Dr. Coselli have done it, of course, before. So I'm looking forward for Dr. Shrestha actually to talk to us regarding the acute dissection cases. Thank you, Chad, and thank you, Arminder, for this kind invitation, and thank the society for putting this webinar together.
Good afternoon. So first of all, I want to thank the STS and Dr. Arminder and Chad for inviting me today. I do not have any disclosures here. First of all, I want to pay my respects to Hans Boas, the father of elephant trunk technique, who passed away about 6 weeks ago. So we have to thank him for everything, especially in this elephant trunk technology. So I was leading the core group that designed this graft about 15 years ago. We worked with Terumo Aortic, at that time called Vascotech, when I was still working in Hanover to make this device, and also did the led the first CE certification trial between 2010 and 9/11. And although this graft is new to US, this has been used all over the world now. We've got almost 15 years of experience, and more than 25,000 of these grafts have been implanted. So I'm going to talk about this patient. Was a 50-year-old male presented with penetrating chest pain with cold right leg in a peripheral hospital. Was seen by a vascular surgeon, and he did a diagnosis of thrombosis of the right iliac artery. We see these things a lot in the small hospitals. So he did a thrombectomy of the right femoral artery and the right iliac artery, but the patient didn't get better. So someone else luckily came and said it could be a dissection. They did a CT scan. They found out it was an acute dissection, and then immediately called us and sent us. Luckily, Germany is geographically very small, so the patient had this pain in the morning, and by late afternoon, he was already at our hospital. And the CT scan confirmed that it was an acute type A, DeBakey type 1 dissection with marked perfusion of the lower part of the body. So this is the CT scan of the patient. You can see that the true lumen is totally collapsed. That's why he had these cold legs. The ascending aorta is dilated. The root is also dilated. So we have actually published our techniques of doing this Thoraflex technique. We do cannulate directly in the ascending aorta using the Seldinger technique. And then if one has to do the root, we first start with the root. In this case, we did a David procedure because the root was dilated. The leaflets were normal. And then as soon as we finish the root, and the patient has been cooled to, let's say, about below 22 degrees, we start so-called the beating heart technique, where we perfuse the left ventricle and the right ventricle that hurt in a totally vented left ventricle, then go on a circulatory arrest. First start with a short period of retrograde cerebral perfusion, and then after opening the arch, and then put the antegrade cerebral perfusions. And of course, we have seen the deployment. It's a very quick 10 seconds deployment technique, 3 steps. We don't normally put in a guide wire unless it is a redo or there's a big kinking in the distal arch. Otherwise, in acute dissection, I no longer put in any guide wires. So this is the final picture that it looks like. I'm going to show you one of the old videos. It is, I operated this patient in 2015. You can see it's acute dissection. First did the David procedure and started the so-called beating heart technique. Now in a circulatory arrest, we open the arch. The left subclavian is also dissected here. So in this case, I was using, did the zone 2 anastomosis. We do wash the Thoraflex graft in rifampicin. So you can see that this is still the first generation device. The only difference between first and second is that in the first one, the clip is taken out. In the second one, you can cut out it. So it is very quick. This is the first generation where you just take out the clip. This is what we used in Europe for many years, and until we designed the new device. Otherwise, it's more or less the same 3-step deployment. I would say it takes less than 20 seconds to do that. One has to be careful when you are pulling out the handle that you don't pull out the graft. So I do use these 4-stage sutures so that you can pull up the descending aorta or the distal arch. It helps. Every centimeter that comes up helps a lot. It's just for the stage sutures, because in those old days when we are doing the classical elephant trunks, if you pull up the graft, then it's sometimes difficult. In acute dissections, we do use the Teflon, because the most important thing is that there should be no bleeding at the end. And when we designed this graft, actually, like Dr. Arminder says, we made the collar very small. To open up the graft, I do use these forceps, and most importantly, I'm always using pre-deployment and post-deployment and endoscope so that one knows exactly how it looks like. So this is real-time control. We do not have to go to the CT scan to control whether the graft has been deployed properly or not. So this way you can exactly see if the graft has been deployed properly, especially in redo cases. In chronic dissection, you may land in false lumen otherwise. And then immediately starting the distal perfusion, and then doing one anastomosis after another. Over the years, I think we've done now more than 400, almost 500 Thoraflex implants in Hanover. I personally did maybe more than 300 here. So in these cases, over the years, we've learned a lot. You can see that the heart is beating even at around 25 degrees. So the biggest positive thing about this technique is that we don't have to worry about the ischemia time of the myocardium. And doing one after another anastomosis, taking maybe 1 minute longer so that there is no bleeding at the end. And again, if the tissue is bad, I use Teflon. If not, then no. So this is how it looks like at the end. You can see that even on the pump, it's totally dry. It has to be dry, of course. And then this is the post-operative CT scan. The patient is now 8 years post-operation. He didn't have any problems or any downstream aortic reoperations. So this is the best thing about the frozen elephant trunk, that it stabilizes everything. So there's couple of slides. We've done now, when I was in Hanover, more than 134 frozen elephant trunks in acute dissections. Patients are normally young, below 65, I would say, to do this operation, even in acute dissection, a lot of malperfusions patients, but also you can see that a lot of concomitant procedures. If the root is dilated and the leaflets are okay, I would do a David procedure. If the valve is damaged, then of course you do a Bentel. And you can see that even in these cases, 30-day mortality is comparable to even if you do a proximal arch repairs. The best thing is that in follow-ups, there are no secondary procedures in the aortic arch and the proximal descending aorta. So if you are doing an anastomosis at zone 2, then I would do a frozen. Otherwise, if the patient is very bad and comes in a very bad state, very old patients, I would just do a proximal arch. So we also published it and showed that even after 10 years, 12 years of follow-up, there is no change in the aorta. There is total remodeling of the descending aorta up to the level of where the stent graft is, which is segment A. There is no dilatation there. Even in segment B, which is from the end of the graft up to the diaphragm, there is no increase, minimal increase only in diameter over the years. And even in segment C, there is only a slight increase. We've had, then even if there are problems in segment B or C, one could put in a TIVA, endograft, or then open repairs. So like Dr. Jassar said, I've just moved from the Hanover Medical School to Mayo Clinic, and hopefully we'll be starting this here also. But as it's important that even if we have new devices, that we choose the right technique and the right device for the right patient. This is the best thing that we can do. Thank you.
Thanks, Malakh. Arminder, do you want to start we got a few minutes here, a couple questions.
Yeah, so I'm going to follow your format and then throw 2 questions at each of our panelists first, and then we have a couple of questions in the chat. So Dr. Preventza, 2 questions for you is, what do you think is the advantage of this hybrid prosthesis rather than doing the standard frozen elephant trunk? I mean, how does that make it easier? And then secondly, tell us how you manage your subclavian. So you did a carotid subclavian in that case. Are you sewing in zone 2? Are you sewing in zone 3? does that impact the length of the stent graft that you're choosing? So tell us about those two things.
This is awesome questions, Arminder. So first of all, with regards to the first question, I don't know the answer. That's a simple one. You can ask me, is the Thoraflex really the solution here versus just doing your own frozen elephant trunk? Maybe yes, you do have one device, there is one piece, you don't have different components, so that makes the things easier. Now, if the frozen elephant trunk is actually the answer to a lot of pathologies that we treat, yes, does make things easier. But I think long follow-up, and we just have to see, as actually Malakh make a very good point, is the right, we have to use this technology for the right patients. And I was very amazed actually to hear from the Terumo people that since July, we have almost 100 implants. I never knew that we have so many patients with aneurysms in the United States, and maybe we do. But the question is, we have to make sure that all these patients, they do need the devices, and we just, it's not like we have a nail and we have a hammer and now we have to just make sure that, you know, we use it. So it's really to make sure that we have the right patients. So the second question was about subclavian carotid. Actually, I do think that doing a subclavian carotid really facilitates, and on that particular case that I saw, the subclavian was far and the aneurysm was on the front, so I knew that it's going to be a very, very difficult to get up, you know, get there. And over the last, it's actually more than a year now, but we have done a lot of arches, and subclavian carotid is the way that now we like to do it. Really facilitates the operation. You can very easily ligate it from inside if you haven't ligated through the case, and then you just do like two vessels. So you just have to worry about the carotid and anominate. Now, with regards to the stent graft, I have to say that I'm a little biased on that regarding the length. One of the issues here is a paraplegia. You don't really want to have paraplegia because then you don't really serve the patient by doing the FET. Since they have done that meta-analysis with more than 3,000 patients for the FET, as you know, and they found that the paraplegia increased when the stent graft length was 15 centimeters or more. After that, I'm actually extremely careful. Even when I do antegrade stent delivery, or we do the frozen elephant trunk, you know, handmade, or now with the Thoraflex, not to use more than 10 centimeters. So of course, body habitus is important. The landings, you know, where actually if you're going to go to zone 2 or 3 is important, but I think just keep it simple. Keep it 10. If the patient is going to need another procedure down the line, that's fine. You don't have a paraplegia. This is important. Having a paraplegia on this patient, you didn't really do anything, you know, great. So I think the more you do, the more you learn that you have to be very careful in these cases. Thank you.
Thank you. Great. Dr. Shrestha, so you probably have the world's largest experience in Thoraflex, probably, you know, certainly as an institution, but probably also as a single implanter. So my two questions for you are, one, who should be doing these cases? You know, does the device now make it easy? Should it still be the people who are doing the, you know, experienced surgeons who are doing the total arches already? Are those the people who should be using this, or does this now expand the pool of people who can now do total arches that weren't previously doing total arches because of this hybrid device? And then my second question to you is, what do you see are some of the limitations or the drawbacks of the device or the technology as to what patients this may harm? We heard about paraplegia, but what are some of the other lessons that you've learned?
So the first question, of course, the total arch replacements are, I believe, the most traumatic surgery that we can do in a human body, because there's going to be circulatory arrest. It's a long operation. So unless someone is trained as an aortic surgeon, I don't think anybody should be doing it. And especially in dissections, even in Hanover, I made it a rule there that if one had not done 20 total arch replacements in elective patients, I did not allow them to do frozen elephant trunks in a dissection case. I think this is important. This is going to make life easy for us, but doesn't mean that everyone be able to do it. So the second question comes is that one has to understand that although this device is new to US, this device has been there for 15 years. That means that when I sat down with the Terumo people in 2008 with the engineers to design this device, we used the technology and the knowledge I had at that time. So this is a 15-year-old technology. Only in US is new. So that means that the stent itself, like you correctly said, was actually the stent that was used for the Anaconda device. So it had a ring stent design. And also when we designed that, actually, because we are doing the island technique, and I designed it for the zone 3 implantation. The first 100, 150 I did, I think, in zone 3. Now it is being used in zone 2 or zone 1. So as soon as you do that, the stent part is not curved. So you have to be careful and look at the pre-op CT scan of the patient, how the aorta looks like. If there's a lot of kinking, then you can land into trouble. So this is all about choosing the right patient. The second is that I think, like you rightly said, there have been some lessons that we've learned. One is that there has to be a landing zone. If there is no landing zone, and especially in aneurysm patients and the whole descending aorta is large, you cannot use this device like a classical elephant trunk because there is no longitudinal stent in the stent part, so that these are ring stents, so it can fold in itself and you can have thrombosis. So this has been a problem. It has been described. We've also actually presented it in many meetings in EAC. So you have to have a landing zone. And the second thing is that there shouldn't be no oversizing, maximal oversizing. If you do oversizing, because at the end of this device, there is this ring, and that can cause dilatation, especially in Marfan patients. And we've learned it the hard way. And we had to do, within 6 months, a redo descending replacement because there was dilatation. So no, I would say oversizing, especially in dissection, if the descending aorta is, let's say 30 millimeters, I use a 30 millimeter graft, no 35, 34, or 36, right? That's important. And again, this makes our life easier. I would say that especially in younger patients below 65, in Marfans, or then I would do a total arch replacement with a frozen elephant trunk, even in dissections. But one has to be an experienced aortic surgeon. That's very important.
Thank you. A lot of follow-up questions, but we are already over time. We do have 2 questions in the chat, which I'm going to throw to, first one to Dr. Desai and the second one to Dr. Watkins for a brief answer. So Dr. Desai, this is those two are competing devices, right? You could use either the TBE or the Thoraflex to treat the arch saccular aneurysm portion. So, how do you pick one versus the other? Is one better suited than other? What are some of the conditions that you pick one over the other?
Yeah,
you only have 1 minute.
I think they're very complementary. I think that if you can do the complete repair with the Thoraflex device, that's a great concept. So mid-arch saccular aneurysm is great for that. If you need to do a more complex TVAR going down further, you're going to extend it anyways with more TVAR to get down to a celiac as a separate procedure. In that situation, I prefer zone 2 with a TBE completion.
Dr. Watkins, I'm going to throw the second one to you. What are some of the cost and the billing implications for the hospital for these devices? Have you encountered that yet?
I'm probably the worst person to ask for that because I'm not really sure. I don't know much.
Are expensive.
Yeah. I don't know much of the difference of the cost and price, say, between a zone 0 TVAR with a side branch versus a carotid subclavian versus, open case. I'm sure open cases has much higher reimbursement, but these devices are obviously more expensive than what preceded them. So I'm not sure. I haven't run into any of those issues yet.
Yeah. For Thoraflex, there's a new technology incentive right now. So even though the price of the device exceeds the individual component price of the stent graft and the surgical graft, in some patients, based on what their insurance is, in the end, it may actually end up being a wash for the hospital. In some cases, the price may actually be beneficial. But I'm not sure about the TBE. Dr. Desai, Dr. Hughes, do you have any insight into that?
No, they have an NTP for that as well, but I'd be very cautious about that concept. That because of the various discounting and proportionality that goes on with that, that actually the actual amount of dollars the hospital returns on something on an NTP sometimes is only a few $100s. So our group has looked at that very closely in our institution, and I don't think it seemed to us like that was a very a meaningful financial incentive, but I would look at it directly at your institution and your payers.
Yeah, I agree.
Well, I think we're out of time. Great job, everybody. Thanks for everyone who joined, and I guess we'll see you next time. Have a good night.
Thank you. Bye,
Thank
everybody.
you. Bye.
Thank you.
Thank you.
Thank you so much to our moderators and our panelists for their participation and insight tonight. And of course, to our sponsors, GORE and Associates and Terumo Aortic. Thank you. Join us for the next STS webinar on Thursday, November 10th, as an interdisciplinary panel from major cancer centers across the country discusses the current management of resectable stage 3A non-small cell lung cancer in the era of immune checkpoint inhibitor therapy. Details now available on sts.org/calendar of events. Register today for the STS 59th annual meeting and plan to reconnect with your colleagues in San Diego. STS members receive a registration discount, so learn more and register at sts.org/annual meeting. You can scan in the bottom left-hand corner as well. Thank you so much and have a wonderful night.